this very interesting discussion with Mr. Papadopoulos that really showed the future. Let us move back to reality, the Greek reality. And as Ilias Pirtounias has said, let us view the more effective approaches in the management of patients and the role of data in health. And allow me to make a brief introduction before we launch our discussion. The pandemic, therefore, has proven how important it is to have access to health data so as to exploit them scientifically and attain better results in well-targeted treatments. The European Commission has realized the huge importance of that data and has set as a priority the creation of a European space of health data until 2025. Specific European countries such as Finland have made quick steps ahead and already exploit health data to the benefit of science, patients, and the health system of the country. Our country has been discussing the issue of exploiting e-prescription data. No other country has the quality of our data, which is a real treasure. But we have only been discussing it ever since 2004. I wonder what impedes us, and we cannot follow suit as other member states so as to exploit that data. Because the data of the GDPR is not the cause, because other member states already exploit that data. Could you please hold your time at 6 minutes so as to have time for discussion? So I first give the floor to Mr. Anagnostopoulos, who is the Secretary General of the Ministry of Digital Administration. Good afternoon. Thank you for the invitation. The question was straightforward and the introduction. Allow me, however, to start my address in continuing the previous session and the excellent dialogue between Mr. Papakilas and Mr. Papadopoulos, who also spoke of subjects having to do with Greek innovation and to what extent this is feasible, given the factors that have to do with the diaspora, because the Greek diaspora, as we've heard, is smaller than that of Israel. And I would like to point out that especially our country has the great prerogative to have an excellent academic diaspora, because on the basis of surveys conducted in the past, I remember Hellenic Bank, Bank of Greece survey done, it has been demonstrated that Greeks that have started their studies here and are now in foreign universities has an excellent record in high caliber publications. And I believe that this might be something which would be desired, not because only it is desired by them, but would be nationally beneficial, so as to invest in the innovation forces and to have them back in the country. The second thing that I would like to say is that thinking about sensitive data, in order to process that, one needs the appropriate infrastructure, and we have lately managed to have excellent infrastructure that we have offered to the field of health, such as electronic platforms, for instance, Zoom and so forth, for the various sectors, or the cloud infrastructure, which is being developed, but also through networking, that we will have the excellent network connections and therefore infrastructure. All that is necessary so as to have good, efficient services offered. Now, let me dwell on the issue of data that you touched upon. Indeed, data is an issue, and I will not speak strictly of medical data, but I will speak of the data in public administration. We have managed to hold an extremely successful experiment of vaccination. This was unprecedented in our country as well as in all other European countries. So we managed to integrate in this vaccination and set the priorities and integrate all the Greek population that were eligible. Some 8.8 million Greeks were set in list of priority, and this has led to an automated process of setting once dates, appointments, and getting vaccinated. So that means that not only did we exploit all the platforms available through SMS, web, citizen centers, drugstores, we also managed to have all citizens in a way so as to have them cover that date. This happened for the first time, and that meant that we could deal with problems. This was not to be taken for granted, neither has it happened before. And this was a success that allowed our country to have a vaccination program that which was globally acknowledged as technologically successful, but also based on data that allowed us to build those applications. In other countries, this was not attained, yet we managed, and we did it because we had the possibility to process that data and build applications that were created on reliable data. Therefore, the key for all that was interoperability. What you also say about medical data, this has to do with the broader sphere of interoperability, which allows a citizen to make a demand, make an application to the state, and retrieve all set of information, such as the case of Fuel Pass, for instance, or other kind of platforms, where, for instance, a citizen files an application and we can retrieve immediately data, whether he has paid the traffic dues and all that information. So he doesn't have to scan documents, have them checked and all that. All that takes place automatically, both in observing GDPR and on the consent of the citizen. And this is most important because now we have a citizen that with a single citizen's application, we have another 6 actions taking place and being affected in the background by us. Therefore, also the example of vaccination certificate was such an successful example. This certificate in our country, as was presented by the Prime Minister, offer the possibility to be innovative in the foreground and demonstrate that we have innovative ideas which are being adopted and can move ahead. With regard to interoperability, it is right and necessary to find the common rules so as to find, identify, collect and retrieve that data. There are simple queries which are not easy to answer unless you have the appropriate quality of data. For instance, the father or mother who wanted to make an appointment for the child, unless we have the necessary data at the necessary registries, this could not be attained. Unless we have the possibility to know that someone has the specific data and has indeed the possibility and the power to set an appointment for the third party, that would not be available. So in order to be able to offer a wealth of services to the citizens, it's necessary to have the appropriate data, so as for the data to be clean and reliable. Finally, it is very important to have security services. That is where one can exploit with additional security factors, as it happens with the bank transactions, as it happens with the responsible declaration and power of attorney, and whenever one needs services that need further classification. So that's why we have a registry where one may have secured a mobile number, and therefore we can have the renowned code reaching the mobile phone and corroborating one's identity and being authenticated when using some applications. The multiple communication channels are also important, serving the citizen. The data of public administration are not separate from that health data. These are the data that allow us to have the wealth of health data combined with services that one will need so as to build the whole ecosystem of the overall services. Finally, with what you mentioned vis-à-vis data processing, all the solutions have been proposed and adopted at the European level. We move towards that direction. We know very well that there are limitations that have to be observed, But in order to be able to extract useful data for the future, for demo and other surveys, we must have the possibility both to process indices in a macro level, but also and macro level as well, so as to retrieve the appropriate information. Thank you. This is in guise of introduction. Thank you for observing the time. It is a fact that what you said, even 2.5 years ago, will be science fiction. We speak of hundreds of millions of transactions when some 3 years ago we started with from 8.8 transactions in 2018, 34. This year we will be concluded with 1 billion. We hope, as the Minister, Mr. Pierakakis, has said, we will be reaching 1.5 billion. What's most important, it's not merely the number that is in most transactions. It's not that a citizen enters, it's what we do behind it on the citizen's consent, so as to retrieve all that necessary. It doesn't have to do anything. So these are transactions for which the citizen doesn't realize what we do, but there are so many transactions that we do for him without him knowing about them.
Right, I should now like to give the floor to Mrs. Tsouma. She is the president and the CEO of a very particular organization. It's not very, well, people are not used to seeing that in other European countries. It's IDIKA. Okay, so I have a presentation there. So she's president and managing director. I have a presentation there. So do we have the presentation, gentlemen? Let's bring up the presentation by Mrs. Tsouma. So how do I control this? Right, so just speak out loud, say next slide, please. You'll just say next slide and it will change automatically. It's voice activated. Right, so thank you very much. So the organization, that is a rather particular one, is the organization that is IT based. It is especially built to support the healthcare sector with health information systems. It's a health ICT that handles and manages the ICT of the Ministry of Health. So we are de facto required and needed to do and deal with big data. So big data were created from all these years of operation of the healthcare systems, which we are called upon to process and elaborate in order to move on to the next steps of the evolution of health services addressed to the citizens. So this big data has some characteristics. All organizations are seeking those tools that will allow them to utilize big data. Same as with our case. So let's go and see very, very fast the 4 V's of big data and how they find application in the big data of health, and especially the IDIKA health big data. So the 4 V's are that the volume is particularly large, particularly extremely high data download speed. The second V is velocity. The third is the extremely wide variety of data, variety, and the quality of the data and the reliability to be true, veracity, is the 4th V of big data. Now, in our case, and starting with the first feature, which is volume, the data that we have as IDIKA or the Ministry of Health, or as the state, if you'd like, is around 800 million prescriptions, 300 million referrals for 12 million patients from 50,000 physicians, from 10,500 pharmacies and 2,650 diagnostic practices. This is built and set up from a number of daily exchange and introduction of data from all these points. We know very well that every day citizens visit doctors, every day prescriptions are filled, every day prescriptions are made, every day referrals are drafted, and every day referrals are executed. So we need velocity, speed. Now the speed and velocity at which these things happen today is exceptional. All these data are exchanged among all these focal points very, very fast. The doctors know it, the pharmacists know that, and they experience it every day. Regarding data form, obviously these data could not be processed in the way we're discussing about were they not in a specific structured form. So they are entered in a structured form as per the rules of IT for these big data, which is why we have fast access and reliable as well. Yes, because they are data created using specific rules from the source. And there is no other intermediate processing of these data. And these data, at the moment, are utilized via a BI system. There is a BI system that we use so as to have the information available when needed and where needed. How is this information collected? Well, information sources are rather numerous. They're all third-party systems of all manufacturers and partners of the physicians and pharmacies. They are primary healthcare. They are e-government, through which citizens come in contact and with all systems and all other systems of Greek administration. They are My Health, the patient health record, which is built by this exchange, the My Health application, which is the last service for the citizen where we exchange and find data. They are the various registries, like the COVID registry. They are the LIS from various centers, diagnostic and hospitals. And they are the e-health certificate system. So there is a full, complete exchange of information from the systems in which the data are created towards the e-prescription system. Here again, quite indicatively, I have put on the slide some numbers regarding the volume of data we are called upon to process. And here the way these data are created. Here I have some numbers that talk about the millions of visits, the number of citizens who have activated paperless prescription, e-prescription, the number of intangible prescriptions, the e-prescriptions already handled, and, well, intangible communication is one that we're in a very proud position to say that is used by an increasing number of citizens. Because it's just that. It's a digital service. There is no paper to be used and to intervene in the communication between the citizen, the doctor, and the pharmacy. Where do we use and utilize this information today? Where does the Greek state and the Ministry of Health use this information? We monitor and control pharmaceutical expenditure. We create individual patient registries that are very useful both in prevention and treatment of these illnesses. Another area is the identification of vulnerable groups, and our first successful exercise was the one mentioned by the SG. We located those vulnerable groups that were indicated by the patient, by the groups of doctors, to prioritize in vaccination, and they were located and identified through the utilization of these data. We didn't expect each and every citizen who is or considers themselves as vulnerable patient to come forward and prove it before the hospital or actually the vaccination system. We identified them, we gave them priority in the vaccination system, and then their appointment was already prepared for them to receive their vaccination first. Proof of the fact that we do in fact utilize the data is the next pages you can see on my slides. You can see various statistical analyses regarding the utilization of data from the e-prescription system. I will not spend too much time on these. Moderator says we have another minute. Yes, I will not insist on these because it's pointless, because I want to show several ways in which we today and every day utilize this information for the monitoring and control of pharmaceutical expenditure, and is available both with the Ministry of Health, with the EOPYY, and any other organizations and agencies need this information to perform their duties, to draft strategies and policies. So this BI system is now fully in full use for utilizing the data. Further utilization regarding patient registries has to do with the various and individual information regarding specific patients and specific conditions, and therefore the monitoring of their progression individually. At the moment, we have the cystic fibrosis registry, the COVID-19 patient registry, the COVID-19 vaccination registry, people in the influenza vaccination registry, registry of childhood and adolescent neoplasms, and registry of vaccinations of children and adolescents, which means that individual utilization is also performed of this individual data. Skipping forward, I should like to say that there are many ways to present statistical information from a BI. I showed everything. And in conclusion, I will skip forward to the next thing. I wouldn't want to take up too much of your time to say that finding any individual categories and groups, starting from the vulnerable groups or any other groups, and assemblages of patients are needed by the healthcare system to be able to provide them with services or to perform preventive medicine, is already a given in our country. And preventive medicine is something that we've already started as an action, where really there we dip into that ocean of information and we fish out those specific people who need to be, for instance, notified so as to perform the preventive checkup or preventive medicine or whatever, or preventive activity. So, in conclusion, big data benefits our health. At this point, I should like to thank you very much for your attention. Thank you, Mrs. Tsouma. I have followed the progress of IDIKA from 2012, since it was in the cradle, actually. You've made leaps forward. I mean, everything we saw today was science fiction 10 years ago. I should now like to give the floor to another organization and their representative, Mr. Kikilias, who is contract director with the National Organization for the Provision of Health Services of the EOPYY. I think it's the second largest social security fund after the AOK in Germany. So will you stand? Will you take the floor? I have a presentation. May I borrow the remote, Dr. Tsouma? Thank you.
Good afternoon. Thank you for the honorary invitation. It is a great joy for being again this year in the Health World Conference. I'll start by what has been said by most speakers, that we are in transition at the European level for establishing the European space of health data, and the European Commission has set very specific goals, especially with a view to exploiting all that data, promoting innovation, and of course in full observation of GDPR. These goals should be, of course, translated and transposed in national level, and it is the dialogue in Greece is mature, I believe, for respective agency. You will see, however, that it is very mazy environment. Data is collected everywhere. We also collect data not only through IDIKA, but from secondary education. We knew ERGs are expected, but how come that EOPYY has a central role? Because it uses 6 billion euros so as to produce and buy health services through a broadened health suppliers. So the cooperation with IDIKA is self-evident. It is the biggest public contractor in the health system. We have already sent for very important DRGs, as mentioned in the morning. We weigh all the needs, analyzing data. We promote clinical excellency after having processed data to have at our disposal, and thus we have led to innovations and reforms. Let me show you an innovation of EOPYY. Many years ago, a small team of people with great scientific knowledge and in cooperation with the Hellenic Radiotherapists Society designed the so-called radiotherapy. Through this model, we managed to control in digital environment all the expenditure pertaining to radiotherapy. We know the plans, we know the planning and the sessions that take place, and for the whole health system, both public and private sector. And you will say something specific. What have we managed this way? First of all, we can pay. The reimbursement was not evident the previous year. And we create the appropriate environment so as for us to know in real time the needs of patients and therefore establish joint lists for people in need for the appropriate radiotherapy without any additional time delay. Another element are the multi-genes therapies related to breast cancer. I have the honor to be in charge of the negotiation committee with the companies. After a broad study in our organization and viewing the cost-benefit analysis deriving from such agreement, we arrived to such an agreement and had special type contracts on high criteria. But at the end of the day, we would like to know how much we would were to spend. So we saved 1 million euros. If you think that most of you come from pharmaceutical companies, there was a curtail of 80% of expenditure of patients that would go through this examination without having redundant chemotherapies. And of course, a huge social benefit for those women. Going on quite recently, I can break you here the news that next week we will announce the contracts with companies that are able to offer the organization bioindicators for mutations, brackets A1 and 2. So in these cases concerning some 2,000 women, this is a specific target group, we managed through negotiation to save another 500,000. Many high value and high quality agreements are signed. And let me refer precisely the data because it also concerns hereditary cancer. So one must know the personal data of the third person. And we have introduced ISO 27000 for the labs that are involved in these therapies. Quality is a central quest for all insurance companies, especially the paying ones. A first study was made. We analyzed all the labs, and from this data collection, both from IDIKA and the other agreements that we have at hand, we managed to create the models on very qualitative criteria for the payment of the radiotherapies. In the next stage, the audit of all expenditure will take place in real time. There are innovative machines, and when we speak of health technology and state-of-the-art technology, There are state-of-the-art machines that can transmit pictures, images to our center and know in real time whether an MRI should be affected or not. You have 1 more minute, Mr. Kikilias. Yes, I'm concluding. Of course, we do not stop there. We already prepare new projects. We try, through the broadening of the digital portal, to come closer to citizens. We have already launched the dialogue with specific target group patients, such those suffering from diabetes or renal diseases, to have in real time the administrative support from employees in our agency. And of course, we need a state-of-the-art business intelligence that we will run stochastic models so as to forecast our needs. So in conclusion, I'd like to say that definitely this is the time to view how we'll exploit this digital transformation and on the strategic planning that is set through the RRF and the funding offered. For us, it is sine qua non because by exploiting that data, we can establish the services, the health services to be offered by EOPYY, and use that data as payment tools so as to attain the best possible agreements on qualitative criteria. This is the minimum, I believe, because the use of data is to the benefit of all. Thank you. Thank you, Mr. Kikilias. And last but not least, let me give the floor to Mr. Gogos, the professor of general medicine and director of Metropolitan. And I have to comment that your calm voice of briefing, of appeasing us, but also of alerting us whenever it was needed during these 2.5 years of the pandemic, along with other eminent scientists, has been of great value. I have been following you and watch you every day through mass media.
Thank you very much for your kind words, and I must say that I really did enjoy the previous presentations. I'm truly glad because, well, now we have in the country the foundations to start what we've been talking about all these years as clinicians, which is to have data in our hands. And then I would like to say that what Mr. Anagnostopoulos said was a huge success with the vaccines that was unprecedented for Europe even. Now, for Mrs. Tsouma, I would like to say something that should go without saying. She mentioned that we know in Greece how many vulnerable populations we have, the immunosuppressed and the heavily immunosuppressed, because when one is drafting health policies, it's impossible to do it without this information. We didn't know how many vulnerables are in Greece, and I think we're close there. Now, this, I must say that we do have multi-gene testing before the chemotherapy. These were biomarkers that were considered expensive, but when you take a look at the cost effectiveness, it's clear to see that everything goes well. These are huge steps forward. Now, like Mr. Apostolides said, that we have data and information from the e-prescription. Why don't we have the data that this information can yield? And my question is, how can the average Greek, your garden variety Greek, and I as a citizen have direct access? And congratulations without you doing your ministry with the financial data, the e-wallet that we have, etc. And why don't we have the personal health data, which is even more valuable? So we still have a long way to go. And I would say that I, as a clinician now, I'm a doctor who is in the first line, has been in the first line for 40 years. I used to hold high staff positions as a director of the medical service and a chairman and governor of a hospital and so on and so forth, but also as a professor, because all these things have to do with education and research. Data provide food for research as well. It's very useful in our country. So what do we want at the moment is to have real data on patients. The medical record, the personal medical record. We all know that, and if you don't know that, I will inform you that a patient who comes from the family doctor to the health center, and from the health center they're referred to the hospital, and from one hospital to the other hospital, and then they're re-referred to their family doctor, there is no personal file and record following them. So you need to expend financial resources to redo x-rays and CT scans and MRIs and everything. So it's absolutely necessary for the patient, for the attending physician, and for the health system to streamline the provision of services and the financial services, to have the personal medical doctor, to have all this data. I think it's something that's starting now and we can move forward. Another huge issue we have the world over and in our country is to collect the real world data, which is extremely useful. Why? Well, because they confirm the data of clinical trials that are currently running. It's not what we really see in real life. We have new treatment, therapeutic interventions that need to apply to the actual people, because each country has its own particularities, its own diseases, its own patient profiles. We have vaccines, where it's very important to have real-world data in order to communicate them to the people. And all this must be done soon, because they will yield a lot of data which will rationalize and streamline expenditure and the offer and provision of services. Also, we have the epidemiological data which we need to have available at some point. I have the honor of being a member of the National Committee on the Pandemic. And what we've been seeing that it's necessary is data, be they epidemiological or real-world data or whatever other variety of data there is out there. So it is of the utmost importance to have that as well. I'm talking about real-world data, but also disease and condition epidemiology. Let me bring an example of successful recording in Greece. It's COVID and the HIV. It's the only two conditions on which we have data, because treatment depends on recording, monitoring, and processing of data. And I should also like to point out that, well, in our country we do have some successful processes and some best practices. I would like to refer to what happens with the multi-resistant and the poly-resistant bonds. Now, we are currently registering them. There are a lot of programs like the EOPYY program, the CLIO of the Niarchos Foundation, and a Horizon project that is out there. Well, we have now these multi-resisting diseases and conditions, and the recording is the data that will come from real-world data in our country will lead to the appropriate interventions, because interventions without data are difficult and many a time disorienting. And another huge thing and a huge success, and I want to close with this, it's a huge success of our country that is based on the SIP team that I'm coordinating now. We have collaboration with 56 different hospitals in the country, and through the collection of data on COVID, epidemiological data, we managed for the first time in Greece, I think it's unprecedented, to have an equivalent, which is an interleukin-2 inhibitor on COVID disease, to make it, to allow it to be approved through the EMA. And now we're in negotiations with the FDA for them to issue their approval. And this is based on the discussion and collaboration of many clinics in Greece, and a tremendous data we have on SIPs and COVID. This is all. I don't want to take up too much of your time, and I would like us to go on with the discussion.
That has been extremely interesting, and this proves that this effort, I believe, was launched by Greece. Yes, mainly from Greece. That was my question. We'll start from the last so as to conclude with the first speaker. Therefore, I consider this is a real example on how an attending physician or the infection doctor society can use the data produced so as to give feedback to the ministry to make the appropriate decisions and perhaps curtail the expenditure, because certain treatments are far cheaper than others, and better exploit the health resources. Am I wrong? No, you're absolutely right. You know that the European Data Center, I think you mentioned that, and in Greece there must be some central service that will be collecting data from work groups. It's not only infections. The cancer doctors also have such teams. The blood doctors, the gastrointestinal physicians, there are such groups, and there must be a central database in the Ministry of Health so as to have much data collected as a country in order to cooperate with other countries as well on equal footing. I admitted saying that there's another step that was made because we also need biomarkers. A positive step was also ODP establishment, that is the Organization for Quality on Health Data, because thus they may be asking specific data from the whole health system. Nice, quite a characteristic example, therefore. And I will address first Mr. Kikilias and Madam Tsouma because they go hand in hand, those two organizations. How can we, and what will be the role in the decision-making process, Mr. Kikilias and Madam Tsouma, in the reallocation of resources within EOPYY? We've heard the minister say in the morning that he is in a very difficult dilemma how to allocate the resources. And we also heard Mr. Papadopoulos of Biogen, who says that we must invest innovative treatments on genes, which cost a lot. So therefore, this might be a tool for saving resources. How do you view things moving as far as EOPYY is concerned? I agree. It is very important to analyze data. Actually, we also have an ongoing discussion with SPHE, that is the Hellenic Association of Pharmaceutical Companies, on how we'll be using biomarkers. Through such procedures, EOPYY has managed to conclude agreements by gaining money. Of course, this is not money to be distributed as dividend to shareholders, but in order to shape the appropriate environment so as to have enough pooling, so as to attract investment for R&D and have new treatments introduced, and have the appropriate profile so as to have the patient who will be taking the appropriate treatment without having someone other losing this chance due to rebates and clawbacks. Same question to Madam Tsouma, adding that data, of course, having full coverage and protection of GDPR, what are the problems that you view and how can they be solved so as to have that data anonymous and have access granted to the pharmaceutical companies? Because all that is valuable, and the pharma industry is disposed to spend millions on such terms in order to have access to that data. Well, we must tell you that, first of all, we are merely an IT organization who do not make decisions, but we can offer our data to EOPYY, whomever other public agency, in order to make the appropriate decisions. And we are the body, the public body, so as to pursue the same discussion, that can be this central agency of IT. I reiterate, we do nothing more than that, that will be able to coordinate and create the appropriate technological platforms so as to offer information. The particular efforts of a research group or another research group of a hospital are obviously beneficial, but at the end of the day, we must have an organization that will collect all that. We will have common laws and rules, because there must be an interface of the data collected in two different organizations, so we can play this role as far as information is concerned. That is, we can be the coordinators and have the edge ground that is incoming, so as to have all the data in a common space under the umbrella of the Ministry of the Health and available to those needing it. We already have anonymization of data whenever it's needed. The issue of availability of data for statistics, over access of data, especially in the field of pharma industry, is institutional. It's not technical. Technically speaking, Well, obviously, technical approach and potential and capacity exists. We should solve the institutional problems, issues existing. And again, this is not in my realm of responsibility. Thank you, Madam Tsouma. Let us conclude with the Secretary General that we all know that is not, of course, the person making the decisions. We must observe the time. I'm sorry. We only have 25 seconds at our disposal. We haven't observed the time. We're already lagging half an hour in our agenda. But we can have the discussion on a bilateral basis later, after the end of the session. So let us conclude with the Secretary General. We know that the Minister makes the decision, but the work is affected by the Secretary General and his staff. So with all those challenges that we've heard here in this session, and having as a tool for 2022-2023 RRF, the Recovery and Resilience Fund, which will greatly assist you in this work that you very clearly described, how do you view the role of Digital Administration Ministry in synergy of the Ministry of Health, having the availability that both Mr. Kikilias and Madam Tsouma presented, and the need for saving resources? Indeed, our ministry, both institutionally speaking and as an accelerator, has helped to organize actions, accelerate them, and it will also be helping in the future for those actions to even have better perspectives to the benefit of the Greek citizen. What Madam Tsouma has said is true. As IT organizations, we can help the work of the responsible agencies, specifically the Ministry of Health, so as to have the appropriate information, so as to make the appropriate decisions. The tools, however, is something that we can help in, as well as in technological and other decisions. In order for all these things to be materialized according to international practices, this is important. It is also true that many projects are integrated in RRF. We'll be viewing a radically different situation in the short and mid-term, so as to have a far better quality and exploitation of data. Let me dwell, however, on something regarding the patient's record. It's true that this record, this path in the course of a patient from the family doctor to a hospital is lost. And in due course, we will be having this record and have the analysis of all the data. But let me dwell more specifically on the subject. In the private sector as well, if someone comes and makes some exams, can one see his data from in a web environment? Is it something that you have secured in the private sector? Even there, at the international level as well, not only in Greece, it's a service which is not offered. We work on that. It demands both technological and other infrastructure, but both the identification of the patient himself between different systems or hospitals and all those actions demand a very cautious planning so as to end at appropriate conclusions. That's what Madam Tsouma said. We plan very cautiously and correctly so as to have the appropriate result. But let me add, as far as applications are concerned, in our country, we have innovative system at a global scale. The patient has access from his mobile phone to the health data that the public sector has at its disposal. I totally agree, because there are also the issues of private security, the GDPR, as we well know, and with insurance and all that. It is a very difficult task. I totally agree that this must regard the whole level, both private and public sector, primary or secondary care. You're absolutely right. I think we have exceeded the time. I apologize, Mr. Infantopoulos. I thank the distinguished speakers. Have a good evening.